Acute pericarditis. This disease is characterized by inflammation of the pericardium, the protective sac surrounding the heart. The pericardium consists of two parts, the outer fibrous pericardium and the inner serous pericardium. The serous pericardium is composed of a parietal layer, which abuts the fibrous pericardium, and a visceral layer, which abuts the surface of the heart. Between the parietal and visceral layers is the pericardial space, which normally contains a small amount of fluid that helps minimize friction between the heart and pericardium as the heart contracts. Pericarditis results from a systemic or localized inflammatory process that involves the pericardium. There is infiltration of inflammatory cells, such as neutrophils and lymphocytes, into the pericardium, often with increased production of inflammatory fluid that can lead to pericardial effusion. The fluid can be serous, fibrinous, hemorrhagic, or purulent, depending on the underlying source of inflammation. Let's discuss some of the potential causes. Systemic viral infection is the most common cause of acute pericarditis. Frequently implicated viruses include Coxsackie virus, echovirus, influenza, and adenovirus. Patients may experience a viral prodrome consisting of fever, malaise, and respiratory and gastrointestinal symptoms. But in some cases, pericarditis is the only apparent manifestation of viral infection. Such patients are often diagnosed with idiopathic pericarditis. Myocardial infarction is another frequent cause of pericarditis, which can occur in a bimodal distribution. Peri-infarction pericarditis results from local inflammation and typically occurs less than 4 days following myocardial infarction. In contrast, post-cardiac injury syndrome, or Dressler syndrome, is an immune-mediated pericarditis that occurs several weeks to months following myocardial infarction or other cardiac injury. Other causes of pericarditis include autoimmune diseases that result in pericardial inflammation, such as systemic lupus erythematosus and rheumatoid arthritis. Uremic pericarditis is another form that can develop in patients with renal failure due to accumulation of blood urea nitrogen and other waste products. Malignant pericarditis can also occur due to metastatic spread to the pericardium, and is most common with breast cancer, lung cancer, and lymphoma. In addition, mediastinal radiation therapy can damage the pericardium and is another cause of pericarditis. Now, let's go over the clinical presentation of acute pericarditis. Chest pain is the hallmark symptom of pericarditis and is typically sharp and pleuritic over the anterior chest wall. It is typically worsened by deep inspiration and lying flat. The pain characteristically improves with sitting forward, as this position reduces pressure on the parietal pericardium. Low-grade fever is another common symptom and is related to systemic inflammation or an underlying infectious process. Patients also usually have some degree of pericardial effusion. Another characteristic finding is a pericardial friction rub, a highly specific sign that may be heard during cardiac auscultation. It is often described as a triphasic high-frequency grating or squeaking sound best heard at the left sternal border with the patient leaning forward. The diagnosis of pericarditis involves both clinical and laboratory evaluation. A thorough history and physical examination focusing on chest pain characteristics, positional exacerbation, and associated symptoms such as viral prodrome are key to diagnosing pericarditis. Patients suspected of having pericarditis frequently undergo further evaluation with ECG, chest X-ray, and echocardiography. Typical ECG findings are due to widespread inflammation of the subepicardial myocardium, causing diffuse ST segment elevation with upward concavity. This can be differentiated from the ST elevation seen in myocardial infarction, which is typically localized and more likely to have downward concavity. Chest X-ray findings are often unremarkable, but may show cardiomegaly if significant pericardial effusion is present. Echocardiography is more useful for detecting small pericardial effusions, the presence of which can help confirm the diagnosis. Because pericarditis is an inflammatory process, patients often also undergo laboratory testing for inflammatory markers such as C-reactive protein and erythrocyte sedimentation rate, which are typically elevated. Now, let's go over the potential complications of acute pericarditis. Cardiac tamponade can occur due to rapid or large volume accumulation of pericardial fluid that restricts cardiac filling. Manifestations include hypotension, tachycardia, and pulsus paradoxus, which refers to an exaggerated drop in blood pressure during inspiration. Constrictive pericarditis can also develop over time due to persistent inflammation from chronic pericarditis or recurrent episodes of acute pericarditis. The resulting pericardial fibrosis impairs diastolic filling by restricting expansion of the heart, causing elevated venous pressure and potential heart failure. Most patients with idiopathic or viral pericarditis are treated with medications to reduce pericardial inflammation, including non-steroidal anti-inflammatory drugs, which decrease production of inflammatory mediators, and colchicine, which disrupts microtubules to inhibit the activity of neutrophils. The prognosis is generally good with appropriate treatment, and most patients experience resolution of symptoms within a few weeks. For other causes of pericarditis, treatment can involve the use of various anti-inflammatory agents, but also focuses on appropriate management of the underlying condition, such as initiating dialysis in patients with uremic pericarditis. Although complications are relatively uncommon, cardiac tamponade is a potential cause of acute mortality, and affected patients require urgent pericardial fluid drainage. Development of constrictive pericarditis can lead to substantial chronic morbidity, and the only definitive treatment is pericardiectomy. To sum up, here are the key points to remember. Pericarditis refers to inflammation involving the pericardium, the protective sac surrounding the heart. It can be caused by a number of underlying conditions. Viral pericarditis is the most common cause. Other conditions include autoimmune disease, renal failure, myocardial infarction or cardiac surgery, malignancy, and radiation therapy. Clinical manifestations include sharp pleuritic chest pain that improves with sitting forward, fever, and a pericardial friction rub. Characteristic ECG findings include diffuse ST segment elevation with upward concavity. Some degree of pericardial effusion is also usually present on imaging. Complications are uncommon, but include cardiac tamponade and constrictive pericarditis. Most patients with idiopathic or viral pericarditis are treated with anti-inflammatory agents and have a good prognosis. Treatment of non-viral pericarditis often involves appropriate management of the underlying condition.